The name Jean Dubussy was what we started this whole conference with, the master of masters who taught us so much. And our French colleagues have so much revolutionized orthopedic surgery. Here in North America, we frequently forget about that. That goes into orthopedic trauma, that goes into pelvis and acetabular surgery, and that goes certainly into spine surgery. It is so cool to have, finally, after all these years here, Vincent Arlet, who is truly one of those visionaries who's come over to our shores and for many years really influenced spine deformity surgery. He's a French artist, surgeon, and worldwide navigator in sailing yachts doing transatlantic races. It's great to have you on the Pacific Coast, and we'd love to hear your thoughts on spinal deformity surgery, the breakthroughs, the insights that you've had at the more, I hope it's not over, towards the nexus of your career. So thanks for coming here, Vincent. Huge honor.
Thanks very much, Jens and Rod. So I've been very impressed by the talk this morning about robotic and navigations. To be honest, do lots and lots of navigation, I love it. It's on my boat. In spine surgery, I haven't done much navigation, so I was very impressed this morning. I thought it was way over my head, this navigation, especially that I've been retired now for 1 week. Can I have my first slide? How do I...
That was my fault.
Okay, thank you. No problem.
Okay, let's see.
So it's
History?
yeah, that's it. Okay, so that's the one from this morning, or is it the old one? Do you know if that's the one from this morning? Okay, so let me go over the breakthrough and spinal deformity surgery that happened in the last 100 years and even more. So just try to go forward like this, no? So, that's okay, I'm just gonna do it here. So obviously you all know about Hippocrates and his attempts to correct the spine with external means, and it was like a torture for the patients. Now talking about the French, we talk about Dubussy, and Jens talk about me. I don't know why you talk about me, but if we go back to the French history in scoliosis, it was started by Dr. Guérin in 1865, and he thought that to cut the muscles of the spine would be able to correct the deformity. And he did a series of 1,349 patients. And obviously, you could expect it had a horrific effect, and it even led to one of the first remarkable lawsuit in medicine. So it was not a good idea. Not everything is a good idea. And then we go back to the United States in 1914, where it's Hibbs would start to do a scoliosis surgery, and he was decorating the spine and putting the graft to hold the spine with the tibia. And as a matter of fact, I did this early in my career, neuromuscular curve. So you would take the medial cortex, the tibia, and once you put the rods in, you apply it, you put it below the cross-link. It would give a beautiful, beautiful spine fusion. So some patients who have absolutely no bone, and this may still be an indication just to, if they are paralytic patients, to use the tibia. This would give 25% correction, but it has a significant amount of pseudoarthrosis that you could expect. A jump to the 60s, we obviously this breakthrough with Paul Harrington using the rod to distract the curve. And he was achieving fantastic results with already a 50% correction. The caveat was you had to get a bed rest and cast for 3-6 months and then brace for another 6 months. And obviously you had some arthrosis. But we can still see in our clinic patient who had Harrington rods for 30 or 40 years who did very well, and they only come in the late 60s, 70s because they have adjacent segment disease or flat back. A little bit later in the 80s, Lucky came with the first segmental instrumentation where you could tackle each vertebra and just bring it back to the to the midline, to the rod, and this was very powerful. There's still a role for this when you think about all your sublaminar band to hold and to prevent proximal junctional kyphosis, or when there is no pedicle at all, you may want to find a way to fix your vertebra. So don't forget about the principle of Eduardo Lucchi with the segmental instrumentation, most likely nowadays with a sublaminar band. And Dubousset with the Cottrell, as a matter of fact, Cottrell was retired when he devised this instrumentation, so maybe there's still room for me to work. So he devised with Dubousset this instrumentation, which was fantastic because it was one of the first instrumentation that could prevent the patient from having a brace post-op. It would derotate the spine, at least derotate the rod, and get a segmental fixation of the spine. It was mostly devised with hooks initially, as it was a spin-off of the high-turn rod principles with more hooks everywhere, and then segmental fixation. Then came the pedicle screw instrumentation, obviously, which was a breakthrough in the scoliosis world, introduced by Raymond Wakami in 1970, and Arthur Steffi just brought it into the United States. So remember that in the United States there was the huge litigation, a lawsuit against the pedicle screw instrumentation that Arthur Steffi started, but obviously that was the way to treat the patients. But it was associated with a big issue initially, at least medico-legally in the United States. These pedicle screws are allowed to correct the scoliosis in much better fashion. This was applied obviously to scoliosis, as you can see, with nowadays segmental at all the levels, deformity, especially in the adult. I'm not sure it's necessary to instrument to put 2 screws in each vertebra in all the cases, but anyway. On the anterior side, you had some pioneers of the anterior surgery, and it was started initially with the Japanese, but Hoxton was the one who popularized the anterior surgery for tuberculosis early in the 1960s, doing a retroperitoneal approach or transthoracic approach, and putting the bone graft in the front after debridement of the spine. And he had a huge series of anterior surgery that would stop the Pott's disease and heal it. Alan Dwyer was a thoracic surgeon to introduce his instrumentation for correction of the lumbar and thoracolumbar curve. You could use a staple and a screw and a wire to and a cable, and a cable that was threaded in the different screws. You would compress, and then you would get correction of the scoliosis. And this is still applying the principle of the vertebral body tethering. So it was a little bit abandoned, but then it came back again with the vertebral body tethering more recently. Zielke expanded the principle of the Dwyer instrumentation. Instead of using a cable, he was using a 3.5 millimeter rod that would give better control of the vertebral body and some derotation. He had a derotation tool that could allow to get the rotation of the spine. Still, again, mostly for the lumbar and thoracolumbar curve. And then you had the more recent adaptation of the Zielke principle using 2 rods plus or minus cages. Remember this short anterior fusion from the Dwyer-Zielke Hams principle, derived as well from the work of John Hall. And I think this technique is somewhat forgotten in some lumbar thoracolumbar curve, where I see a very long, extensive instrumentation going to L3 or L4, where a short instrumentation would have done the job. Or even I see similar cases where they do vertebral body tethering down to L4, and then where a simple 2-level or 3-level anterior fusion would have done the job very nicely. Going to the anterior surgery, Randy Best introduced the vertebral body tethering. That was an excellent principle in a young patient who still have some growth potential on the concave side. You do correction and you let the concave side grow to correct the curve. And this is definitely has been a breakthrough in the spine deformity in pediatric scoliosis, and it's been adopted more and more. It's interesting to see now it's been adapted as a hybrid system. So you would do fuse the thoracic spine and you would just do a vertebral body tethering for the lumbar spine to keep mobility and motion of the spine. So still in the anterior surgery, we had the OLIF transverse psoas, pre-psoas technique that came, and I think this was another breakthrough in the spinal deformity surgery. Whether you do it a mini open or transverse psoas through the tube, the principle remained the same. You go and you have to remove the disc. If you want a good correction, don't forget that you have to resect the ALL. Everybody who tells me that they can get correction without cutting the ALL doesn't work. You get subsidence in the front. So if you want to get good correction, you have to resect the ALL. But it gives you a fantastic correction. This is a case you can see, previous fusion down to L5, very severe flat back, but two discus space, one at 5.1 and one at 2.3. And by doing simple surgery, an ALIF at 5.1 and a lateral at 2.3, you get the job done. So, and then afterwards, posteriorly, you only have to put the rods back instead of doing a pedicle subtraction osteotomy, which probably would not have been enough. You would have required to do more than a PSO to get the correction in this case. So this was a game changer when we could do this great correction through anterior surgery and avoid the three-column osteotomies. Obviously, talking about three-column osteotomy, in some cases you have no other choices than to do a three-column osteotomy, and this was a breakthrough in correction of the spinal deformity. It was introduced in the mid-85 by Thomason. It was doing this for correction of ankylosing spondylitis. This is a case, obviously, with a severe ankylosing spondylitis, and where you can see one PSO is not going to do the job. So you have challenges to position the patient, and you do a 2 PSO, and you get the correction to regain the sagittal balance for this patient with one PSO that was done at L4 and the other one which was done at L2, at L1. Along the three-column, the pedicle subtraction osteotomy, the vertebral column resection was also a game changer in correction of the spinal deformity. Introduced initially, the first one in 1922, and then Leatherman, Lukey, Bradford was doing anterior vertebral column resection, and then it was introduced, just more popularized by Sisuk and Lenke a little bit later. And then you can see that you can achieve a fantastic correction. This is a patient with cervico-thoracic kyphosis who I did a PVCR, and then afterwards I had to do a lumbar pedicle subtraction osteotomy to get the overall alignment. But this is the only way to do this type of correction. You can get also severe deformity and that require VCR, like this patient with a 3D deformity with the head totally rotated in one plane in kyphosis and with lateral bending, and you do a vertebral column resection, and you get the correct sagittal correction of the head, at least straight. We knew that the patient would have some further issue in the lumbar spine, but she's been very happy with this result, that we didn't have to extend her, at least initially. All these different pathology were possible with the advent of the cage technology introduced by Jürgen Harms in the mid-'80s. Then you had obviously the expandable cages and the hyperlordotic cages more recently that were a game changer for correction of the deformity and treatment of the deformity. This is a patient who had a wing sarcoma, who had radiation therapy. He was doing fine. He was healed from his wing sarcoma. He had kyphosis, but then he broke his rod. So we thought that going only posterior in this patient wouldn't do the job. And he had broken his rod 5 or 6 years after the indexer surgery. So this is a patient where we use the cage technology at multiple levels in the front. And then a posterior rod with 4 rods, make sure we wouldn't break his rod. How about the hyperlordotic cages and the cage in the front? I think that's been a breakthrough in the spinal deformity surgery, making in many cases the pedicle subtraction osteotomy of VCR obsolete. This is a patient who had a Harrington rod, a severe flat back, as you can see. But to get correction of deformity, you need 45 degrees of correction. But she has one discus space open at 5'1", so you go anteriorly, you put hyperlordotic cage at this level, and the job is done. Posteriorly, you only have to put the rods in. And this patient was discharged on post-op day 3 or 4, I don't remember. But to some extent, you can think about this being a minimal invasive surgery as opposed to VCR, pedicle subtraction osteotomy in the scar tissue, this patient. This patient did very well. Now, for the correction of deformity, you had another breakthrough. So I think that we should mention the spinal cord monitoring with the advent of somatosensory evoked potential in the 70s, which was the first way to monitor the spinal cord. However, you had 20% of the case that could not be picked up by somatosensory evoked potential alone. So came the MEP in the 80s, popularized in 90s. So in 2000, it became kind of state-of-the-art to use a motor evoked potential to treat spinal deformity. I think it's a key thing. It allows us to do safely a big reconstruction and correction osteotomy. And now I wouldn't come to, I think, most of us not to do this type of surgery without spinal cord monitoring. Along with this spinal cord monitoring came some guidelines for the best practice and the safety in spinal deformity correction. I think the work of Michael Vitale was fantastic, just having consensus of multiple different spine surgeons to give what you should do when you have an issue of spinal cord monitoring during your case, whether it's a stable spine or unstable spine. I think this has been very instrumental for the safety of our patients, as we can treat all these deformities, but obviously there's a safety concern, and I think Chris Shaffrey would arrive just going to talk to us about minimizing the complication, and that's another breakthrough spinal deformity surgery, how to minimize the complication. One word of the other breakthrough, I think I've seen many technical breakthrough robotic surgery this morning, but I think we should talk about the EOS, the imaging studies that we had to assess the deformity. Why it's a key? Because it made us better surgeons. We could think better, understand better what was going on. I'm going to give you an example because first thing to treat a patient, you have to understand what the problem is. So this is a patient who has a serious sagittal imbalance, but she also has a hip flexion contractor. If you look at her pelvis, and just represented with the different orange dots, you can see that the pelvis is not completely vertical, but the hips are flexed regarding to the pelvis. So the patient, she had this sagittal imbalance. She was complaining mostly of back pain and radicular pain. So I started to treat her with a lateral 3, 4, and 4, 5, then a posterior 3 to pelvis. And I got a slight improvement of the sagittal vertebral alignment, as you can see. Then she had hip pain. She gets one hip surgery. So with one hip surgery, she gets better sagittal alignment. But she still has the other hip pain. And then she gets the second hip arthroplasty done. And then now you can see that sagittal alignment is good. So don't forget to look at the rest of the spine, the rest of the body. Don't only look at the spine. The patient may have a spine problem, may have a hip problem, that's a hip spine syndrome. You have to think, what should we address first, and how are we going to achieve the good result in this patient? This may require some hip surgery first or afterwards, depending on the patient's symptoms. And that's the overall the history of this patient. You can see sagittal imbalance, anterior surgery, or just spine surgery first, some correction, first hip surgery, some better correction, and perfect correction after spine surgery and 2 hip surgeries. The breakthrough in spinal deformity surgery was obviously the pelvic fixation started by the Lucky Galveston rods in the 80s, and then just to now currently now with the pelvic fixation with or without navigation. Currently, my practice was in the adult patient to put 4 rods because I was seeing too many broken rods after 2 or 3 years. So my go-to in this adult deformity was to put 4 rods, and which resolve most of the time the problem. This obese patient, you can see on the left hand side picture, and which I treated with I think the PSO and then a 4 rods technique, as you can see. Obviously, I was impressed this morning by the navigation robotic. There's definitely the way of the future. And as to some extent, I was happy to have retired last week because I said, my God, otherwise I'm going to need to go into all these things. It's definitely the way of the future. I congratulate all the speakers this morning for this outstanding lecture you gave to me, and if I'm going back in spine, I would just start to do another fellowship with you guys to know about this robotic and navigation. So my history of spinal deformity journey, it's interesting because I started in the hospital for sick kids in Paris. That was an old hospital built in 1778. And I finished another whole hospital, the first hospital of the nation, Pennsylvania Hospital, that was built in 1751. I'd like to thank you for just allowing me to present these different breakthroughs.
That was important and so well delivered by nobody better than you to give us this historic perspective, because it's so relevant for us to understand the difficulty of managing this, the many refinements that have taken place with better physiologic and technological applications, and most importantly, keeping the patient in focus and trying to optimize outcomes. Here's my question to you. If we look at the statistics, there seems to be an escalation. If I'm dramatic, I'd call it an explosion of adult spinal deformity. Have our parameters changed? Have the thresholds been lowered to call something deformity? Or is everything a spinal deformity? And what's going on in our society? Because we see a lot more of these catastrophes with seriously deranged spines. So is there an escalation of adult spinal deformities? Have we undertreated this in the pediatric perspective? Is this a U.S. phenomenon? Is this an international phenomenon? Give us more a global, big picture perspective of the state of spinal deformities.
I think that obviously you have the baby boomers. Obviously, that's an increased number of patients with the spine who just get older. So we have to see to take care of these more older people, to some extent more healthy. But now it's not rare to treat 80 years old patient with a spinal deformity. If it's healthy, it's going to do under surgery. Now you have the fact that before these patients were untreated. When you had a spinal deformity, you were in your late 60s or 70s, oh, you're too old to get surgery. I'm 67. If I have a spinal deformity, I still want to go and go back on my boat or play golf or something. So I'm going to ask one of you guys to take care of my spinal deformity. You can still feel healthy. So there is definitely a demand from the patient. They still want to have an active life and be healthy and be able to enjoy life. And then there's obviously a big push to treat this spinal deformity, and some of us maybe are not well trained enough to take care of these patients. They think they know how to do it, and then you get complications, and you get complication after complication. I think all these complex cases have to be treated in centers where they do I would say minimum of one spine deformity a week. If you don't do one spine deformity a week, I don't think you should do one.
Great question. Then another big picture question. So we've battled for how many caudal levels of the spine to leave intact as motion segments. And we always were trained, in my era at least, of having a neutral bottom level that frequently left us with 1 or 2 motion segments alive. From your large experience, what is the reasonable number of motion segments to keep intact, even if the bottom vertebra is not completely level? Should we go for 4, 5, 3? Is it maybe even sensible to leave just one disc level like L5S1 intact?
Obviously, I have the concern of degenerative disease at the level that left unfused, and the more you, the distal level, the more you include the distal level, the more likely you're going to have it. But if you think of the purely range of motion level, just you can say that each disc at the bottom gives you roughly 15 degrees of flexion extension. So that's already 45 degrees. So if you go to L5, that's only 15. That's not that many. And so I think it's important, especially in young patients, to keep the as many levels as possible. Plus, you have the thing that's not even talked too much about. It's the social life of this patient, and obviously, if you feel the patient to the sacrum, their sexual life may be compromised. It's not a topic we talk too much about it. When there's no choice, obviously, there's no choice. But if you can save some level and stop a fusion at L3, even though if you know you're going to have to extend it to L4 or L5 sometime down the road, 10, 15, or 20 years, I think it's worth it for the function of the patient and the mobility of the patient. Me, I'd rather, in the idiopathic scoliosis, I'd rather stop the fusion at L3, not having a perfect looking X-ray, than to extend it to L4.
Great points, and hopefully we can count upon your expertise later as more discussions come about, but thank you for your lecture.
Okay, thank you, Dan.
In the interest of time and indulging the tolerance of the audience, can we switch